A patient arrives at the hospital requiring an urgent MRI, but the clinical team flags a major complication: the presence of an abandoned cardiac implantable electronic device, or CIED, left in the chest cavity. Medical guidelines provide conflicting instructions for this scenario. The U.S. Heart Rhythm Society offers no clear guidance because of insufficient data, while European guidelines provide a Class 2B recommendation, suggesting the scan only if benefits outweigh risks, without defining the probability of harm. Because of this institutional ambiguity, most medical centers default to a strict contraindication. They choose to completely bar these patients from 1.5T MRI scanners to avoid potential liability. Removing the device generator does not resolve the conflict. As long as the metallic leads remain embedded in the patient's tissue, the perceived risk persists. This forces millions of patients to undergo suboptimal alternative imaging or face the high-risk morbidity of lead extraction surgeries, all based on a theoretical danger. The central concern is radiofrequency-induced lead tip heating. This illustrates the antenna effect. A fractured or abandoned lead captures electromagnetic energy from the MRI, concentrating it at the microscopic tip. This heat could cause myocardial injury or trigger unpredictable device resets. These safety warnings are derived from in vitro phantom models. These are saline-filled plastic torsos used in laboratories to simulate human MRI exposure inside of a controlled setting. In these plastic phantoms, the physical length and geometric orientation of the lead dictate exactly how much thermal energy is generated at the tip. Current clinical standards are anchored to how a piece of metal behaves inside a box of salt water, which fails to account for the dynamic environment of the human body. Laboratory models predict catastrophic heating, yet retrospective clinical data consistently shows a near-zero complication rate. This raises a critical question: why doesn't the physics of the lab translate to the patient? The first flaw in the laboratory model is the assumption of a perfectly uniform radiofrequency field. Inside the complex, non-uniform anatomy of a human being, such a field does not exist. Humans possess a primary heat sink that phantoms lack: flowing blood. This constant, high-volume flow actively washes thermal energy away from the lead tip. This prevents the wire from reaching temperatures high enough to damage the heart muscle. A second mitigating factor is electromagnetic coupling. Adjacent leads in the chest cavity interact with the abandoned hardware, effectively diffusing the deposited radiofrequency energy across multiple points, rather than allowing it to concentrate at a single tip. The human cardiovascular system actively neutralizes the thermal buildup that laboratory phantoms passively accumulate. Researchers recently completed a retrospective analysis of 80 patients with abandoned leads or fragments who underwent 107 clinically indicated 1.5T MRI examinations. The scope of the study was broad, covering 126 distinct body regions, including the brain, cervical spine, abdomen, and lower extremities. The hardware involved included both intact abandoned leads and much smaller fractured lead fragments. This shows the extreme variance in hardware length. Abandoned leads had a median length of 57 centimeters, while fragments averaged just over 5 centimeters. Based on laboratory physics, this massive length discrepancy should result in wildly different heating risks. This cohort provides a comprehensive, real-world stress test of the rigid MRI contraindication, representing diverse patient anatomies and hardware profiles. If the antenna effect is the primary driver of risk, then the specific geometric orientation of the lead should be the ultimate predictor of patient danger. Researchers used radiographs to categorize 126 leads into specific shapes, identifying the random configurations left behind in the chest wall. Panels A and B show vertical and horizontal fractured fragments, representing the smallest hardware in the study. Panels C and D represent the long, sweeping geometries of C-shaped and R-shaped leads terminating in the right ventricle or superior vena cava. Panels E, F, and G display complex orientations, including Z-shaped, 7-shaped, and tightly coiled leads. If the laboratory models were accurate, these distinct geometries would produce highly dangerous and wildly different risk profiles when placed in a 1.5T scanner. Across all 107 MRI examinations, the results were definitive: 0 deaths, 0 significant arrhythmias, and 0 adverse clinical events within 30 days. Researchers also analyzed the electrical performance of the cardiac devices, measuring capture thresholds, sensing, and impedance to catch any sublethal hardware degradation. To confirm these findings with statistical rigor, researchers applied a multivariable generalized estimating equation analysis. This model tested whether specific variables, lead orientation, length, the region scanned, or scan duration, were associated with changes in device function. Looking at the p-value column, every single variable resulted in a value greater than 0.05. This indicates no statistical association between the physical shape or length of the wire and any change in the performance of the device. The data shows that the specific physical geometry of an abandoned lead is a theoretical risk that collapses when confronted with clinical reality. Within the entire cohort, only 3 patients, about 2.8%, showed a significant change in their device settings. These changes were limited to minor decreases in atrial or ventricular sensing and thresholds. These cases did not require emergency intervention or hardware revision. They were managed through simple, non-invasive device reprogramming. This safety margin was maintained by following a strict protocol, keeping the specific absorption rate, or SAR, below 2 watts per kilogram. SAR is a metric that measures the rate at which radiofrequency energy is absorbed by the body during the scan. By maintaining these power limits and programming the devices to an asynchronous mode, risks are reduced from physical trauma to minor, manageable software adjustments. Currently, patients who need advanced imaging are often forced to accept CT scans, which provide suboptimal diagnostic detail for many conditions. In extreme cases, patients undergo surgical lead extractions, using tools like this laser sheath to pull scarred wires from veins, solely to qualify for an MRI. These extractions expose patients to significant risks of morbidity and mortality that could be avoided. Clinging to the antiquated physics of laboratory phantoms ignores the proven safety of in vivo imaging. It is time for clinical guidelines to reflect the reality that these patients can safely receive the scans they need.